Hello, everybody. As co-chairman, along with Dr. Neil Mehta of the CME committee, I would like to introduce all the speakers today. And it's my pleasure first to have Dr. K.V. Gopal Krishna. He's Associate Director, Chair, Department of Medicine, Chief Infectious Diseases, and Clinical Professor of Cleveland Clinic, Lerner College of Medicine. He has been a great mentor to me and many other physicians over the many years he's been at Fairview Hospital and Cleveland Clinic. He's the 99 recipient of the Master Teacher Award from ACP, ASIM Ohio chapter, and the recipient of the American College of Physicians Ohio Laureate Award winner. He is also a baseball fan and serves as a team physician for the Cleveland Indians. Today, he'll be talking about COVID. As an infectious disease expert, I welcome him to come and start talking. Thank you, Dr. Gopal, for joining us.
Good afternoon. Hopefully you all can hear me. Thank you for the invite. I have been involved in taking care of the patients with COVID-19 since the beginning of the pandemic here in Cleveland. We starting to see patients at Fairview Hospital around March 14th. That is our first case of COVID-19 got admitted. And so we've been seeing patients since then. And, unfortunately, you can see the pandemic is really gaining a tremendous amount of strength. We have had at least 3 surges now. The beginning of the pandemic in March, and we took a break. And sometime in the summer, we started having another surge. And the worst surge is currently going on now. And we have seen the worst of it. It has been going on even worse than what we originally started seeing patients with COVID-19. I will not go into the number of cases what we have seen in the United States, because you all know, in the newspapers, they always update you. We have reached, unfortunately, the bad hallmark of reaching more than 250,000 deaths in this country. We can talk about the overall mortality in the hospitals being small, but unfortunately, when you look at the folks, particularly the elderly and the members of the family dying, it is really unfortunate. I think we are yet to find a vaccine, which hopefully will be soon available to us. And we will be able to hopefully thwart this pandemic transmission. I just wanted to, the next slide, please. I want to show my next slide, a little bit of the experience what we are having in COVID-19. And is there a possibility to move my slide, or should I do something? Here we go. Excellent. This is an update as of December 3rd. And let's go to the next slide. And this actually depicts what is going on in the community, in the United States, and everywhere. And as you see, our hospital experience, we have seen almost, as of December 3rd, we have seen little more than 1,000 patients. And let me go back to the previous slide, where jumped a slide there, which I was going to talk a little bit more about the age group. And as you see here, our pandemic has a sort of a bell-shaped curve. Most of our patients are in the age group of 50 through 80. And then we have a small group of patients anywhere from 20 to age group of 50, and then a small group anywhere from 90 to 100. We are not a pediatric. Somehow.
Dr. Gopal, you muted yourself.
Dr.
Can you
Gopal,
hear?
you have muted yourself.
Okay, can you hear me now?
Yeah, we can hear you now.
Okay, sorry. I think this Zoom is sometimes goes and mutes itself. But anyway, the slide was showing you what's reflected in the, not only in Fairview Hospital, but also overall what is happening in the country. Most of the patients we are seeing, as I said, in the age group of anywhere from 50 through 90. And then another group of patients we are starting to see, particularly with this surge, a lot of young people from 20 through 50, although we are not a pediatric hospital, so we do not see that many pediatric patients in the hospital. The next slide depicts the sort of a male to female ratio. We are approximately the same. We had male about 565 male and 525 female. So the really the male to female ratio doesn't seem to be significantly different. The next slide shows you a little bit about our mortality and where we are. And also we talk about a little bit of the ratio of the race. For example, as we know that the mortality rate is high in the Black race, and we do not have, from our hospital, we do see a lot of whites, and there are a small population of Blacks and a small population of Hispanics and other races. So that is what this slide was showing. And then we want to go into a little bit of the mortality. Our overall mortality at Fairview Hospital has been about 7.5%. And that is really, when you look at larger hospitals, we are doing very well at Fairview Hospital. And our average age of patient who has expired is about 77. And then if you look at the mortality from the age groups, that pie graph shows you a little bit of the mortality rate. And as you see, majority of them are in the age groups between anywhere from 50 through 90 years of age. And we have less mortality in patients who are less than 50 years of age. And there is really not much of a difference in patients who expired between the males and females. We had 42 deaths in males and 40 patients died as females, sex. So really not much of a difference between the male to female ratio as far as the death rate goes. The race also, again, as far as the, because our predominantly we see whites in our hospital, it is hard for us to tell as far as the expired patients. We do have a lot more whites expiring, but I don't think it is the right way to say the output in the outside of the Fairview Hospital, because we do not see that many Black patients or in our hospital. The last slide, which I wanted to share with you, is a little bit about the management. This is the questions many times people ask. CDC continues to talk about shortening the duration of the quarantine. Current way of thinking is that patients who have mild illness, we would like to keep them at least quarantined for 10 days, at least 24 hours of without any fevers or significant symptoms. And then they can come out of the quarantine, although we still advise them to wear the masks and do whatever they need to do to protect the others. Patients who are moderate to severely ill, meaningly the patients who have been in the intensive care unit, have been ventilated, the current recommendation is those patients should quarantine themselves at least 20 days from the day they become positive. And the reason for that is more sick patients would probably have a higher viral load, and they probably have a continue to spill out more virus in their secretions, and that's the reason why we want to stretch them a little longer. The CDC is looking at even reducing the number of days even further. I think this is all based on the scientific data. There have been data to show that as the patients move on from the day when they got infected, their replication of the virus really reduces, and therefore logarithmically reduces. And therefore, every week, their viral spillage is less than what they were spilling 1 week before. So this has all been studied. So this is based on the scientific data. What do we do in the hospital? When the patients come to the hospital, obviously we tell most of the patients to stay home because there is really no reason to coming to the hospital and overload our hospital beds as much as possible. Stay home, take Tylenol if it is high fevers, and try to move around a little bit because we don't want to be developing pulmonary embolism, and then self. But if you end up coming to the hospital where you require hospitalization, we look at two things. How are you oxygenating? If your O2 saturation is less than 90%, there had been data to show that you cytokine release syndrome by using dexamethasone. The dexamethasone is given in milligrams a day. It can be either given intravenously or given by mouth. IV remdesivir is also somewhat restricted. We usually use IV remdesivir in patients who require oxygen supplementation while hospitalized. Again, we look at the margins of less than 90% as our goal. And if it is less than that, we initiate IV remdesivir. IV remdesivir is a 5-day course. We do usually a loading dose of 200 milligrams and then give 100 milligrams every day for 4 additional days. It's a 5-day course treatment. Unfortunately, our beds are getting filled. And so what we are using is a methodology where the patients do well. Let's say after receiving 2 doses of dexamethasone and remdesivir, and they are able to go back on room air and they do not need any oxygen supplementation, we would like to send them home, shorten the duration of the remdesivir, but continue the dexamethasone for a total of 10 days at home. This will help us to relieve some beds so that we can get the patients coming in, so that we will be able to handle the incoming patients. Obviously, if they require persistent oxygen, we will keep them. If the patients deteriorate in the hospital, they will be requiring more and more oxygen requirement. Those are the patients who go into the intensive care unit. And there are 2 modes of treatment we do, either high flow oxygen, and if they don't oxygenate well, even on high flow oxygen, we end up intubating them. I'm not an intensivist. Our intensivists are very good. They try to minimize the intubation time and the ventilation time as much as possible. But unfortunately, there is a lot of comorbidities involved, patients who are obese, who have obstructive sleep apnea, who are smokers, have COPD, and other immunocompromising features. They end up staying a long time in our intensive care units. We sometimes even have to do tracheostomy and eventually end up sending some of these patients to long-term acute care units also. The treatment plan is about the same. We try to restrict the use of antimicrobial therapy unless it's absolutely needed. Obviously, longer you keep the patients intubated, they are exposed to hospital-acquired infections, and so ventilator-associated pneumonias can occur, and we have to manage them accordingly. So that is about the management, what happens in the hospital. What are available right now is 2 monoclonal antibodies, one by the Lilly and the one by the Regeneron. And that is a monoclonal antibody can only be given intravenously. And the criteria to receive monoclonal antibody is primarily to see whether we can try to keep the patients outside of the hospital by giving the monoclonal antibody so that we can stabilize them so that they don't go into the next set of symptoms getting worse and getting hypoxemic. And so the selection criteria is somewhat vague, but we are looking at some of the patients who are elderly, some of the patients who are obese, and some of the immunocompromised patients. These are the areas where people are trying to give the monoclonal antibody. It is still being worked up because many states are figuring it out how to administer monoclonal antibodies. Where do we administer? Because you need to bring into a set unit where you have to administer them. And so you have to really take all the precautions because these are COVID patients. So you need to have all the appropriate precautions, appropriate PPE, and to provide this monoclonal antibody. So it is still in evolution. So we haven't really learned all of it yet. The last one is vaccines. And as you know, there are several manufacturers are doing the vaccine preparation. And this is a very unheard of because usually any vaccine takes about anywhere up to 5 to 10 years to release with all the phases of studies being done. This is an unprecedented way of releasing the vaccine. It's a matter of months the vaccine is available, right? There are various ways to prepare these vaccines. The two vaccines which are going to be released by Pfizer and Moderna are what we call as a RNA messenger vaccine. This is not a viral particle. You take the RNA and fool the body to look like you are contacted with COVID-19. The body produces the antibodies. And so that is how the antibodies are prepared in the human body. So this is through the RNA messenger technique. There are obviously, there is another vaccine, AstraZeneca, I believe. They are most likely are doing and taking an adenovirus and making some mutations and to behave like COVID-19. And then you administer that vaccine for the humans to produce the antibodies. And there is another one called as a split vaccine, and that is subunit vaccines that is still under scientific data, which is not released yet. So they are still studying that, and we are not ready to release those vaccines yet. So the CDC has met, I was told, and I was told that the FDA met last Friday, and again, this is a news all from the media because I have not heard any scientific data, but that is available soon. And most of the hospitals in Ohio should be getting it by middle of December. And the way to distribute, today's Plain Dealer has a nice article about that in the front page. You can read about that. I think the vaccines are going to come in batches. Some of them are going to the hospitals and some going to the two major drugstores, CVS and Walgreens. And they in turn will distribute this vaccine to the nursing homes, the skilled nursing facilities to create. So currently the vaccine is recommended for the healthcare workers and then to the most vulnerable people in the skilled nursing facilities. And obviously, as we get more vaccines, it's going to be released to the others. The two vaccines which are released needs to be put in sub-zero temperatures. It should be kept in minus 100 degree Fahrenheit freezer temperature. So apparently the National Guard is going to take care of that. And again, it is all being prepared as to how do we get those vaccines to administer to the patients. So we all have to learn about that and stay tuned for further information. So this is where I will stop. And I don't know whether we are going to the question time or we're going to wait until the end.
Dr. Mehta, Dr. Kumar, what do you want to do?
Yeah, I was checking out the other site and it looks like there's been no question submitted yet. So if Dr. Gopal, if you can hang on for a little bit,
Sure.
we may try and accumulate the questions and post them to the panel at the end. That might be
Okay.
the best way to use the time. I really appreciate your time. Thank you so much.
Thank you.
Thank you, Dr. Gopal.
Rupesh, are you going next?
Yes.
Okay. Vikram, I guess if you want to introduce Rupesh. Need to unmute yourself.
It's a great honor to introduce Dr. Rupesh Raina. He is the president of Aipno, an avid researcher and a great teacher and a physician. He's a nephrologist with the American Kidney Institutes and holds many distinctive titles. He's board certified in multiple specialties, including pediatric nephrology, pediatrics, internal medicines. He's had his education in fellowship at Rainbow Babies, pediatric nephrology, Cleveland Clinic nephrology, internal medicine and pediatrics at Metro Health, and research in urology at Cleveland Clinic. I can go on and on about him, but the most important thing this year has been he's been a great leader at Aipno and successfully pivoted quickly from the traditional CME to a more progressive, easily reachable online version in the midst of the epidemic. Of course, with the help of Dr. Neil Mehta, we did great CME sessions earlier this year. So let me introduce and have Dr. Rupesh Raina talk about lupus nephritis, the importance of active and early diagnosis. Thank you, Dr. Raina.
First of all, good afternoon, everybody. And it's hard to follow the footstep of Dr. Gopal. I personally want to thank Dr. Vikram Kumar and Dr. Neil Mehta for their exceptional help this year for the CME during this pandemic and doing the youth activity. It has been an exceptional year for our online teaching and giving their personal time, voluntary time, despite being in such a big practice and also busy in the research. So my special thanks from the Aipno Executive Committee and from the Board of Trustees and all the members to Dr. Vikram Kumar and to Dr. Neil Mehta. As a nephrologist, I get this talk, and thank you for Arena for supporting it. And actually the disclosure is that Arena is going to support our CME for this year. And now I want to talk about the lupus nephritis. This is something coming along very well, and with a frequent and serious complication, and how can we prevent the lupus nephritis and how it could be further diagnosed. So if you look into the rheumatological guidelines, the lupus nephritis has been subtle and been missed by many of the rheumatologists itself and the internal medicine people, because a new guideline that we came up with lupus nephritis is that if you have a proteinuria on a dipstate more than 0.5, or you have more than 5 to 6 RBCs in the setting of an active lupus, then you have to look for a lupus nephritis. And that's the guideline that has been followed by the KDICO in some form. Another thing, lupus nephritis comes up with the constellation of multiple organ. I call this as a syndrome than a lupus nephritis itself. And it entails the CNS, heart, kidney, and definitely the blood and other vasculitis syndrome. Overall, the prevalence is around 73 per 100,000 patients. Females are about 9 times more likely to have SLE than males, and Blacks have the highest prevalence. And here I also want to add also the Asians are very prone to the lupus, and especially the Indian populations and Asian populations are getting more infected or getting more involved with SLE. Now, if you see, lupus nephritis itself is one of the rarest complications of the lupus, and it is defined, or it is classified into 6 classes. But now if you look into this, the data, lupus nephritis affects up to 45% of the patient with lupus in US. And patients with lupus nephritis are likely to be female 90% of the time. And non-whites are Black, Asian, and those of the Hispanic ethnicity, and are more likely to develop lupus nephritis than the whites. And compared with white, Blacks and Hispanic people tend to have more advanced presentation of lupus nephritis, you can see, and they have more severe underlying histopathology. If you look into the class of the lupus, which is lupus nephritis, has been classified from class 1 to 6. Most of the time when I see an Asian population with the lupus, they really get like class 4 or class 3, which is the membranoproliferative, more destructive, rather than going into the class 5 or seeing less membranoproliferative class 1 or 2. Once diagnosed with lupus, patient has 45% increased risk of the kidney failure and 3 times increased risk of the death, and that needs to be looked into it, and that's why the rheumatology guidelines came up with the early diagnosis and assessment of the lupus, looking into the urine examination, which is just a urine sent out with urine protein to creatine ratio and microalbumin to creatine ratio, and looking into the high power cells for the microscopic and hematuria, look for any kind of distorted RBCs. Now, when you look into the characteristics and factors for progression, this is like a constellation, because up to 30% of the patient with lupus nephritis, they progress to kidney failure within 15 years of diagnosis. And this is how the interaction is. You have Asian, Black race, Hispanic, you have antibodies, vasculitis, you have nephrotic range proteinuria, or sometimes it is hard to kind of prolong or get the diagnosis because the kidney biopsies has been delayed. So it's just a constellation of these multiple factors that lead to the more progressive lupus nephritis. And it also increases the risk of cardiovascular event. And we have done papers which has shown if you have a lupus nephritis, you have 8 times risk of getting an MI and 4 times the risk of getting a cardiovascular mortality, including the coronary artery disease and coronary artery calcification. Now, you have to take into account in these kind of patients also that these patients are also getting a lot of the immunosuppressive drugs with the steroids, so they are more prone for any kind of cardiovascular mortality and endothelial dysfunction, apart from being a vasculitis going on. Patient with lupus nephritis utilizes more health care resources, overall hospitalization rate, and the length of their stay is pretty high when they get admitted. Now, the evolution of the guidelines for the lupus nephritis, and I was involved mainly on the ASN side and the Rheumatology Society, but basically the data has come up from the EULAR trial and the ACR trial. And really, I will suggest the guideline that I use mainly for the lupus is using the rheumatology guideline, which was done with conjunction with a nephrologist. And you can see how hard it is to bring the rheumatologist and nephrologist in the same panel. But if you see that the EULAR trial is the one which is being used mainly in the Europe, and the criteria of the kidney biopsies are very, very important, mainly the proteinuria more than 1 gram in 24 hours or more than 0.5 per 24 hours with hematuria or cellular fast. And this is very subtle. Many times when I see the patients, they have a florid hematuria, proteinuria, nephrotic syndrome. So this is, I will highly recommend from the ACR guidelines in 2012, if you have a proteinuria, just subtle 0.5 in 24 hours, or if you see some kind of bloods more than 5 to 6, that should define or will elude you to send to the nephrologist. And this is our criteria actually to do the biopsy. Or if you have an unexplained increase in creatine. And by the time I see that, it is kind of pretty hard because I already know the damage is done. And we have Dr. Mehboob Rahman joining us in the panel in the CME. He's the chair of nephrology in the UH, and he can add into it more. Most of the time when we see the lupus nephritis, it was a tail end when the patient is already having rapidly progressive damage, class 3 or 4, or we may say at the end, the class 5, which is membranous. Now, this is the classification, class 1 and class 2, class 3, class 4, class 5, class 6. I always tell to the resident, it is not stage 1, stage 2, it's class. And basically it is on the involvement of how much is the damage to the glomerulus and whether there is involvement of less than 50% or more than 50. I have seen a lot of cases in the children's too. When we see diffuse class 4, more than 50 glomerulus, I see the prognosis is a little bit more worse. Membranous, sometimes it's indolent, it goes for a longer time, but definitely class 3 and class 4 will initiate or at least substitute the institution of the immunosuppressions to prevent the progression. And these are class 3A, class 4, class 5, just showing how much the damage the glomerulus have. Early identification of lupus nephritis is essential, yet active surveillance is not routinely conducted. And this is what it is. Patients should be referred for the kidney biopsy upon the evidence hematuria or cellular CAS more than 0.5 of the 24-hour protein, or if you do the spot protein creatine ratio of 0.5 or unexplained decreased GFR. We have in the panel some of the nephrologists. Even nephrologists wait, and I have to educate them. If you have a spot protein to creatine ratio more than 0.5, you have a blood, or you see some 5 to 6 in a high power, that will initiate you not only the nephrology referral, actually for the initiation of the kidney biopsy. Now you can see even a single episode results in significant nephron loss. And I don't want to go into the pathophysiology. It's actually the way the glomerulus are getting injured. It initiates the process of leukoplastic process, more damage to the membrane and the pore size, and what happened, the nephron mass goes down. And the more evidence you get for lupus nephritis, you lose more mass. And that's why ACR recommend that urine analysis, protein to creatinine, and serum creatinine should be monitored every 6 months in patient with SLE, and 58% of the patients with SLE are not getting lab screen every 6 months. Even the nephrologists do not do that, and that's I'm pushing more for the primary care and for the rheumatologist and for us as a nephrologist too. And almost 1 in 8 patients use emergency room as the most common point of care. And definitely we need the primordial, we need to hold these patients, we have to monitor them very carefully. And timely biopsy and treatment decreases the risk of the kidney failure. And delay in biopsy more than 6 months results in 9-time risk of the kidney failure. And more than 3.3 months is associated with lower likelihood of remission. Achieving a rapid clinical response to lupus nephritis therapy reduces the risk of lupus nephritis and morbidity. As you can see, if you target proteinuria, at least 25% by 3 months, 50% by 6 months, by 12 months, the target goes below 0.5 to 0.7. And that's the data of the EULAR trial, which recommend to optimize the kidney function. And again, the early detection in proteinuria level predicts improved kidney function outcome. And that's been shown, and that's been also shown by our paper in pediatric population. Patient survival on the response status, you can see the people who respond, complete response, partial, and non-responder. You can see the patient survival and also the decrease in the GFR, which is kind of very common platform and common source that we have seen mainly for any kind of kidney disease, which also perturb, and it's a reason for progressive proteinuria, progressive nephron loss. Now, complete response rate are low with standard of care first-line therapy. Now, if you see, there is a controversy between the rheumatology guidelines and our KDIGO guideline and URAL trial, which has been done. What the rheumatology guideline says is you have to induce these patients with CellSut. Although these patients, CellSut is good as an induction therapy for class 2 or 3, it makes me nervous between class 3 and 4 because 3 and 4 is very, very fast progressing, and we put them class 3 and 4 as an RPG, and I induce more with cyclophosphamide or use rituximab. And we have also seen that MMF response rate is better in the Asian population, but in Blacks and Asian, MMF is not very good for the induction. Now, lack of FDA-approved treatment options, people are using the abatacept and they are using anti-CD4 monoclonal antibody, but technically there is no investigation done for lupus nephritis over 30 years. EULAR guidelines says you use CellSut or low-dose cyclophosphamide, or you combine MMF with CNI as an alternate, particularly in patients with nephrotic range proteinuria. In patients with a high-risk kidney failures, high-dose IV cyclophosphamide can be used to reduce the total GC dose. The use of IV methylprednisolone is recommended, followed by oral prednisone for up to 4 weeks or tapered over less than 7.5 milligram for 3 to 6 months. And this is very important. You have to taper these medications with the lupus patient with steroid a little bit longer. I always go like 6 to 9 months with a slow taper. And again, reduce glucocorticoid less than 7.5 milligram per day, and still steroid remains the most common mode of treatment. And you can see it comes with the various side effects with eye, with cataract, psychosis, with hypertension, endocrine. So there is also 74% increased risk of developing new organ damage for patients with mean prednisone more than 7.5 versus 7.5. Every 1 milligram per day increases was associated with 2.8 increase in the risk of developing new organ damage. So the issue here is that what we are producing and proposing here is the excessive load of the steroid. Are we targeting the prevention of the kidney damage with the rapidly progressive glomerulonephritis pattern? Is there a role of adding any kind of CNI which could salvage the progress which is going on? Now, you have to be very careful when you induce these patients, as you can see the EULAR trial, with cyclophosphamide. Some of these are young kids. I have 18-year-old kid, and she's not going to produce any OM if you treat them with cyclophosphamide. So you have to have OM to be stored, or you need to talk to them because this is really toxic to the ovaries. Now, if we do, what I will prefer is to use the CellCept, and I have a very good experience with my patient. I induce them with the 2 grams of CellCept and give them a steroid for a short time. I do not agree for maintaining the steroid for the longer time. I give them for a short term, and then I switch it to the CellCept, and then I plan to add a little bit of CNI to see whether the calcineurin inhibitors can be one of the phenomena can help these patients. Now, patients with lupus nephritis are more likely to be women and non-white ancestry, and they have increased renal failure and mortality, and prompt diagnosis is very important. Unfortunately, as a nephrologist, I get second or third referral, and I will see in their record the person has proteinuria and hematuria, 3+ proteinuria, 2+ blood, never been evaluated, and by the time they come to us, they were class 4 or sclerosed. So I think prompt diagnosis is very important. Active surveillance and prompt biopsy. As you can see, the Rheumatology Association has given the criteria that you just do the biopsy on the presence of hematuria and spot to protein creatine ratio 0.5. And Dr. Kumar is here. He sees all diabetic nephropathy, and he can see how endocrinologists have done such a great job on maintaining decreasing the microalbuminuria and proteinuria and progressing the diabetic nephropathy. Achieving an early decrease in proteinuria and complete response to treatment can improve. And as you can see, the EULAR guideline recommending reducing proteinuria greater than 25% by 3 months, 50 by 6 months, and almost by 12 months, they want the range to be between 0.5 to 0.7. So these are the guidelines that's coming in. I was more involved in the rheumatology guideline. And what I have done in my practice is giving a short dose of steroid, induce them with CellCept with a heavy dose, 2 grams, and then add CNI to see which direction they go. So I think the take home was I picked up this lupus nephritis to this, mainly the primary care, and I could see on live session, we have around 485 people listening. I wish that you can pick up the lupus nephritis, which is one of the dreadful complications of the lupus, in your clinic by looking and doing a simple dipstick. And if you see there is a proteinuria, at least do a protein to creatine ratio and microalbumin to creatine ratio. I was always being taught by Dr. Mark Pohl from Cleveland Clinic, if you think it's a tubular proteinuria, always do microalbumin and protein creatine ratio all together, because your microalbumin should not be contributing more than 30% in the total proteinuria. And if it is more than that, it's coming from glomerular. The guidelines is again a frustration, and I see both adult and peds population, I get more frustrated. People do different mode, but I've been more successful combining the MMF, and I'm trying to add the CNI to inhibit and have more progression and prevent the total load of the steroid, because these patients are on a lot of steroid. With that, I want to thank you. And if you have any question, I'm open to answer the question. I also want to thank the organizers for our CME, and thank you for all the people who are on live. And this is the maximum participation we ever had for our CME. With this, I'll give the podium to Dr. Kumar and Dr. Mehta.
Yes, thank you, Dr. Raina, for your excellent presentation. I will now invite Dr. Jain. Dr. Vikas Jain is an associate professor of radiology at Metro Health Medical Center and is actively involved in resident training and education. He also holds the responsibility of Associate Radiology Residency Program Director. He did his fellowship at the University of Iowa and has lectured in many regional and national radiology meetings, presented abstracts and research. So welcome, Dr. Vikas Jain. He will be talking on COVID radiology.
Vikas, you have to unmute yourself.
Thank you for the introduction and thank you for the invitation. It's my honor to be here. Today, I will talk about imaging in COVID-19. I will focus on role of different imaging techniques, and I will mainly talk about when we do CT chest, how to categorize the pulmonary patterns. Radiological Society of North America, which is the main radiological society, that has come with a consensus statement that when we radiologists are reading the CT chest, they should try to categorize the findings into like 4 categories for better communication. Um, then I will show some complications. COVID-19 predominantly involves the chest, but you can see findings in many other body parts. And I will briefly touch upon CT severity scoring, which is a new thing. We can score from 0 to 20, and this is a semi-quantitative method which can give some prognosticating values. So Radiological Society of North America came up with a statement that normal CT chest should not be used to exclude COVID-19 in early disease. Approximately in 10 to 15% of the patients, CT chest is going to be negative. And if we think about the patients who are asymptomatic, then CT chest is negative in those. Therefore, routine screening of chest CT in identification of COVID pneumonia is currently not recommended. And when we see the CT chest findings, we should try to categorize them into typical findings, indeterminate findings, atypical findings, or findings which are negative for pneumonia. Now, what are the typical findings? The buzzword is peripheral, bilateral, ground glass opacities. They may present with crazy paving or with consolidation. So here we see a peripheral ground glass opacity. What is ground glass opacity? Where we see some opacification of the lung parenchyma, it is kind of white, but it is not too dense. And you can see underlying bronchovascular markings and septal lines. When they are more focal, they are more rounded. So predominantly they are ground glass opacities to begin with, and they are predominantly peripheral. Both lungs are involved. There may be some predominance in the posterior aspect and more in the lower lobes. They can be multifocal ground glass densities. If they are small, they are going to be more rounded. So in this different patient, we see ground glass densities in bilateral lobes. Some of them are central, but predominantly they are peripheral. So initially it is more ground glass density, but when the disease progresses and there are more exudates in the alveoli, then you will see they will become more denser. We can also see halo sign and reverse halo sign. Now, what is halo sign? We can see consolidation, which is more dense in the center, surrounded by ground glass density, which is in the periphery. Another example of halo sign, there is consolidation, which is more dense in the central area, and there are ground glass densities in the periphery. This is halo sign. Now remember, imaging findings are non-specific. Halo sign can be seen with many other infections as well. Now this is an example of reverse halo sign. In reverse halo sign, ground glass density will be seen in the center, and in the peripheral portion, you will see a more dense parenchymal density. This is a different patient. You see ground glass density in the center, surrounded by a more dense parenchymal density. This is called reverse halo sign. Now, halo sign and reverse halo sign, they are typically described in organizing pneumonias, but can be seen with COVID-19 pneumonia. So crazy paving, what is crazy paving? You see classic ground glass density, and there is thickening of the interlobular and intralobular septum. So these septal lines are very thickened. Here you can see there is crazy paving, ground glass density with thickening of the septum. When disease progresses, there is like more exudate, and it will develop into a full-blown consolidation. Here you see consolidation. You can't see septal lines. There is air bronchogram, which is like air in the peripheral bronchi. So crazy paving pattern can be seen, and it can progress further into consolidation. So crazy paving name comes from these like stones in the pathway. They are like different in shape, and these are marked by dense lines. So you see crazy paving, ground glass density with thickening of the septal lines. Now crazy paving has many differential diagnoses. It is classically described for alveolar proteinosis, and it can be seen with many other infectious or inflammatory etiologies. So presence of crazy paving doesn't mean patient has COVID-19 pneumonia. You have to correlate with other parameters. Crazy paving can also be seen on chest X-ray. Chest X-ray, we usually see ground glass densities or subsequently like pneumonias, but occasionally you can see some increased haziness with prominence of septal lines, increased opacities, prominence of septal lines. And in most of the patients who are COVID-19 positive, most of the chest X-rays are portable views. Uh, so they have like some decreased respiration. Usually in COVID-19 pneumonias, you will not see pleural effusions. So pleural effusions are usually absent in COVID-19 infections. When the disease progresses, we can see ground glass densities will turn up into consolidation. This is ground glass where you see opacification. Here you cannot see the septal lines, and this is dense consolidation. You see some air bronchogram. So peripheral bilateral ground glass densities can be seen with or without crazy paving and consolidation. So all three things can be seen in same patient. In this patient, we can see there is some ground glass density as well as consolidation. And there may be some area of crazy paving also. But predominantly, they are going to be peripheral and bilateral. So when we see these typical findings that are seen in majority of patients of COVID-19 pneumonia, Radiological Society of North America expert panels suggest that the reporting language should state commonly reported imaging features of COVID-19 pneumonia are present. Other processes such as influenza pneumonia, organizing pneumonia, drug toxicity, connective tissue disease can have similar imaging appearances. But the CT pattern needs to be correlated with clinical context of the patient. We should evaluate the risk factors, exposure, prevalence, history, presentation, lab values, and positivity of PCR reaction. Now shifting to indeterminate findings. When there are absence of typical findings and we see multifocal diffuse perihilar or unilateral ground glass densities. In this patient, this was the only opacity present. This is peripheral, this is ground glass density, but this was the only lesion. So it can't be the typical finding. This should be characterized as indeterminate. And this patient had some other infection. It was not COVID-19 positive. This was a different patient. Here we have ground glass density only in the left lower lobe posterior aspect. No other finding was present. So this was characterized as indeterminate finding, and this patient had COVID-19 infection. In some patients, we will see few and small ground glass densities, and they may be like a couple of them, peripheral. If you see perihilar parenchymal densities, they are indeterminate. Classically, for the COVID-19, they are peripheral. In this case, we can see there is peripheral distribution of ground glass densities, which is a typical finding. And if you see predominantly the parenchymal densities and ground glass densities are perihilar, they are indeterminate, and they can be seen in many other conditions as well. So when you see indeterminate findings, RSNA suggests that we should describe imaging features can be seen with COVID pneumonia, but are non-specific and can occur with a variety of infectious and non-infectious processes. Now, what are atypical findings, which is a third group? When there is absence of typical and indeterminate findings, and if there is consolidation in single lobe or single segment, or if we see small central lobular nodules in a tree and bud pattern. In this case, we can see multiple nodules, and here is a tree and bud pattern which is commonly seen with bacterial or tubercular infections. Here we see a small area of consolidation, but the predominant pattern here is nodules. We do not see any significant ground glass densities. If you see a lung cavity, that is more commonly seen with bacterial and tubercular infections. Or if there is pleural effusion with smooth interlobular septal thickening, that is commonly seen with pulmonary edema. In this case, we can see the right lung is totally clean, and there is consolidation in the superior aspect of the left lower lobe. So this is usually seen with bacterial pneumonias. When you see multiple nodules, either scattered diffusely or in a tree and bud pattern, this is commonly seen with bacterial pneumonias or in tuberculosis or in fungal infections, and would be very rare in COVID-19 pneumonia. So if you see atypical findings, it should be described as imaging features are atypical or uncommonly reported for COVID-19 pneumonia. Alternate diagnosis should be considered. Now there is a fourth category which is negative for pneumonia. These patients may be imaged because they have some respiratory symptoms, but the etiology of their symptoms is something else. For example, in this case, we can see traction bronchiectasis. The distal bronchi are dilated, irregular. There is honeycombing, thickening of the septal lines, and there is some superimposed infection with the cavity. Some of the patients may have other kinds of interstitial lung disease, again bronchiectasis, mosaic pattern, and some interlobular septal thickening. We are seeing pleural effusion, and this patient was also having interstitial lung disease without any COVID-19 pneumonia. Here we see emphysema with large bullae. In this patient, we can see interstitial fibrosis. Fibrotic lines are seen in the periphery, some small lung cysts, clustering of lung cysts, bronchiectasis. Here we see predominantly perihilar distribution of the ground glass densities. It is predominantly perihilar, and this patient had HIV infection and superimposed pneumocystis pneumonia. In COVID-19, predominantly that will be peripheral. So now with the winters, we will see more and more patients with influenza, and imaging findings may be overlapping. This patient presented with ground glass density in the peripheral distribution. There were few other ground glass densities in the peripheral distribution, but PCR was negative for COVID-19, but it was positive for influenza type A. So imaging findings in COVID-19 and influenza can be overlapping. Last week, I was reading some body CTs, and in the visualized portion of the lower lungs, I was able to see some ground glass densities bilaterally in the peripheral distribution. And that was a totally asymptomatic patient as far as chest was concerned, and the patient was being scanned for some abdominal pain or some other indications. And we are seeing the COVID-19 findings that are seen typically as incidental finding. So Radiological Society of North America expert consensus panel recommends that we should contact the referring providers to discuss the likelihood of viral infection. So rather than saying COVID-19, we usually use a more inclusive word, which is viral pneumonia, because same infections can be seen with influenza as well as COVID-19. American College of Radiology has also recommended on similar lines that CT should not be used to screen for or as a first-line test to diagnose COVID-19. CT should be used sparingly and reserved for hospitalized symptomatic patients with specific clinical indications for CT scan. Now, many patients are younger, and when patients are sick and in ICU, then radiation may be an issue. To reduce the radiation exposure, we can think about low-dose CT scan. Low-dose CT scan is reliable in detecting lung parenchymal changes. But if you are suspecting complications like pulmonary embolism, then a CT angiogram of the chest with contrast should be ordered. When we perform low-dose CT chest, there is no contrast, and low-dose CT chest is good enough to look for involvement of lung parenchyma, but it is not good if you are suspecting like pulmonary embolism or other complications. World Health Organization has also given some guidelines for chest imaging. They state that most patients who are likely to benefit from imaging are who have moderate to severe symptoms, or imaging should be performed prior to emergency procedures. Or if you want to evaluate for complications like pulmonary embolism, pneumonia, or pneumomediastinum or pneumothorax. Asymptomatic contacts of COVID-19 patients, chest imaging should not be performed because that is not useful. In symptomatic patients with suspected COVID, chest imaging may be performed if PCR test is not available, or the results are delayed, or if initial testing is negative, but there is high clinical suspicion. Imaging can be performed either by chest X-ray or CT chest. Chest X-ray is less expensive, consumes less resources, very easy to obtain. It can be performed in the room or in the ICU as a portable technique. Radiation is lower, but it is less sensitive. But chest X-ray is a great tool to monitor the progression once the patient is hospitalized or is in the ICU. Chest CT, however, is highly sensitive. It is useful in better evaluation when patient has pre-existing pulmonary disease. Many of these patients have interstitial lung disease, or they are suffering from emphysema or some other bronchiectasis and other problems. In those patients, chest X-ray can be very, very problematic to distinguish whether there is superimposed pneumonia or the patient has the findings because of underlying lung disease. And CT chest is also excellent to detect the complications of COVID pneumonia. More resources are required. After performing a CT chest, it takes approximately half an hour to 1 hour to disinfect their room. So in a busy hospital, it can be problematic if they have only few CT scanners and a CT scanner is down for approximately 1 hour after scanning one COVID-19 patient. Our radiation dose is also higher on CT chest. Now a new technique has come, which is severity score on CT chest. It can help in prognosis for COVID-19 pneumonia. This is work in progress. There is some subjectivity. It is a semi-quantitative method to describe the extent of lung parenchymal involvement. We have five lobes: right upper lobe, right middle lobe, right lower lobe, left upper lobe, and left lower lobe. So each lobe is assigned a score of 0 to 4, depending on the percentage of involvement. So if there is complete involvement of that lobe, it will be 4. If there is no involvement of one particular lobe, then that lobe is going to get 0. If you feel around like 40% of the lobe is involved, it is going to be approximately 2. If you feel around like 60 to 70% of that lobe is involved, then the score of 3 is given. Then you add up the scores of all the lobes, and the maximum score will be 20 when the entire lung on both sides is involved, or it could be 0 if it is completely clean and there are like no ground glass densities. So high CT severity score, along with other clinical and lab parameters, are potential predictors for poor prognosis. So this CT severity scoring is a new thing, and only few institutions are currently using this to describe the extent of lung parenchymal involvement. Now, many patients will have other medical conditions. For example, here we see on a CT chest, the heart is enlarged in size. Bilateral pleural effusions are seen, which are rare with COVID-19 pneumonia. This patient also had some atelectasis, and there were ground glass densities. But this was because of pulmonary edema from congestive heart failure. Apart from chest, we can see findings in many other body parts. Liver can be involved because of cholestasis and because of microthrombi formation in the sinusoids, because of hypercoagulable state. And because of that, we can see heterogeneous enhancement of liver parenchyma. In this case, we can see there is diffuse thickening and hyperenhancement of the ascending colon as well as descending colon, suggestive of colitis. Here we see a more fulminant case of proctocolitis, where there is significant wall thickening of the rectum and distal sigmoid. Same finding on the axial image, significant wall thickening of the distal sigmoid because of proctocolitis. And we are seeing hyperenhancement and wall thickening of the stomach wall, suggestive of gastritis. So many patients will present with diarrhea, vomiting, nausea, and abdominal symptoms. Because of hypercoagulable state, sometimes there will be thromboembolism in the mesenteric arteries, leading to ischemia and perforation. Because of hypercoagulable state, you can see infarcts in the kidney. Here we are seeing wedge-shaped infarcts in the left kidney. COVID-19 can also cause pancreatitis. Here we see enlarged and swollen pancreas with some peripancreatic inflammation. And this hypodensity is a thrombus in the superior mesenteric artery. So this patient is at increased risk of bowel ischemia. And if not treated promptly, it can lead to perforation, leading to pneumoperitoneum. Now, many patients, we see pulmonary embolism, especially in ICU patients. Here we see a saddle embolus with thrombus in the left, as well as right main pulmonary artery and other branches. Here we see a smaller thrombus in the segmental branch of the right lower lobe pulmonary arterial branch. Apart from venous thrombosis, arterial thrombi are also seen. Here we see abrupt cutoff in the right popliteal artery on the CT angiogram of the lower extremity. This patient presented with sudden onset of cold foot with blueness. For venous thrombosis, Doppler study and ultrasound are best, and they are the imaging of choice. But when CT scan is performed for some other indication, we can also see thrombus in the common femoral vein on both sides. The left common femoral vein is expanded, and a smaller thrombus is also seen. So because of hypercoagulable state, we can see thrombosis in both veins as well as arteries. Now, neurological complications are also seen in COVID-19 patients. Whenever there is altered mental status, we should think about neurological complications. Here we see a hemorrhagic venous infarct. This white thing, hyperdensity, is because of hemorrhage, and there is hypodensity because of a venous infarct. And this happened because of thrombosis in the left sigmoid sinus and internal jugular vein. We can see normal contrast in the right sigmoid sinus and the jugular vein, but the left side is thrombosed, giving rise to venous infarct. Here we see bilateral infarcts in bilateral cerebral hemispheres. This can be because of global hypoxic ischemic injury, cardiac arrests. In this case, we can see the arch of aorta. The left common carotid artery is normal, but there is occlusion of the right common carotid artery because of arterial thrombus. And the left cavernous portion of ICA is seen, but there is no opacification in the cavernous portion of right ICA. This will lead to a big infarct on the right side. Now, many of these patients will go into cardiorespiratory arrest because of respiratory problems, and these patients can develop watershed infarcts. On this diffusion image, we can see watershed infarcts at the junction of MCA and ACA distribution. So these infarcts can be seen after cardiac or respiratory arrest. So to summarize, imaging plays a crucial role in management of the COVID-19 patients. There is significant overlap in the chest imaging findings between COVID-19 and other infectious etiologies such as influenza. Similar findings can be seen with drug toxicity or organizing pneumonias. So chest CT findings should be interpreted and correlated with clinical context. Radiological Society of North America has recommended that radiologists should try to categorize the imaging findings as typically seen in COVID-19 pneumonia, indeterminate, atypical, or negative. And we can use a CVT severity score from 0 to 20 to help in prognostication purposes and try to determine how much of the lung parenchyma is involved. This can lead to better communication. And apart from lung findings, many other organs of the body are involved with COVID-19, and this is actually a multi-system disease. Thank you.
Thanks, Dr. Jain, for a fantastic, it was a presentation, very clear, very practical, very useful. So thank you so much. And now it's my distinct pleasure to introduce Dr. Vikram Kumar. You all know him, but formally, he's the section chief for endocrinology and a teaching faculty at Fairview Hospital. He's a chief of medicine at the University Hospital Elyria Medical Center, and he's a fellow of the American Association of Clinical Endocrinologists and has his endocrine practice on the west side of Cleveland. So welcome, Dr. Kumar, and take it away.
Thank you for the kind introduction, Dr. Mehta. I will be talking today on hyperglycemia and beyond, hindsight 2020. We are going to look at today not just glycemic control, but what about the cardiovascular effects, mortality, and complications? Let me take you back to the studies that have been done over the many years and decades, including ACCORD, ADVANCE, UKPDS, VADT. All these were huge studies. And after intense control for glycemia, for glucose, there was not much gain in mortality, cardiovascular death, or morbidity. Of course, the microvascular picture improved. The retinopathy, neuropathy, nephropathy greatly improved. There's tremendous improvement with glycemic control, but not on the macrovascular side. Actually, if you remember, in the ACCORD trial, it was stopped early because intense control causes more mortality. Let me take you to the ominous octet. You must have all seen this, heard this, but I definitely want to touch upon it. The multiple dysfunctions contribute to the pathophysiology of type 2 diabetes. Dr. Ralph DiFranzo, he's the guru on diabetes down in San Antonio, made this. And you can see there's a problem in diabetes with the pancreas is alpha cells making more glucagon, beta cells making less insulin, the muscles not taking up the glucose, the incretin effects from the gut, the brain neurodysfunction causing sometimes people to eat more. Glucose reabsorption from the kidney gets to be increased, which causes even more hyperglycemia in type 2 diabetics. There is less lipolysis, and all these factors lead to increase in glucose. There are also mechanisms and medications which act on all these different ways in which we can improve diabetes. And therefore, we should use diabetic drugs which use different mechanisms. So quickly going to this slide, which shows that even in treating prediabetes, the risk for atherosclerotic cardiovascular disease risk factors is most important. And even for the drugs in diabetes, this is most important. You look at the glycemic control algorithm, you look at the monotherapy, dual or triple therapies. After metformin comes the GLP-1s and the SGLT2s. These are the drugs that have shown cardiovascular benefit, more so in the last 1 to 2 years. You look at the profile of the anti-diabetic medications. This is a great, great slide. If you guys want to look at the different pills and the insulins and the different pharmacy regimens, this slide tells you their pros and cons. Going down to the second and the third column of the GLP-1 and the SGLT2s, if you go down, you see on the cardiac side, you see the green boxes showing there's a benefit cardiac-wise when you use these two newer medications. So going to the GLP-1 positive cardiovascular effects, liraglutide, which is Victoza, was the first to show that there was a positive cardiovascular benefit. Then came dulaglutide, which is Trulicity, and then semaglutide, which is Ozempic. Now, this is a phenomenon that I did not expect, but they have now made semaglutide, which is the oral form of Ozempic, is called Rybelsus. This is a GLP-1, which is an oral medication. So you don't have to give a shot. You can take a pill. It should ideally be digested in the stomach enzymes, but what they have added to the pill is called SNAC. SNAC helps to stabilize the pill. It fights off the pepsin degradation of the pill. It also changes the pH of the lining of the stomach where the pill is sitting to be less acidic, in which the pill sits to the stomach and gets absorbed. There is some caveats to this. It has to be taken empty stomach in the morning, completely empty stomach, with only 4 ounces of less of water, because it shouldn't splash around in the stomach. The pill has to go to the lining of the stomach, sit there, and get absorbed straight into the bloodstream. It's a fantastic thing. It works just like the injection, which is the semaglutide injectable Ozempic. Same effects. It is a half-life about 7 days. Take the pill every day, of course. And it has, however, not yet been shown to have cardiovascular benefit compared to its cousin, which is the injectable form. I guess more studies have to be followed. Now let's go to the next group of medications, which affects the kidneys. The kidneys plays a great role in the glucose balance. The kidneys typically have to absorb about 180 grams of glucose every day, which is filtered. So all the glucose filtered has to be absorbed, so it's not lost in the urine. It's not lost calories. When you see this slide, you see how the glucose is filtered. All the glucose is filtered out into the tubules. The proximal tubule then has receptors called SGLT2. SGLT2 absorbs the glucose back into the bloodstream, as you can see on this little cartoon here. After it is absorbed, there is still some might be left. About 10% that is left is then absorbed by the SGLT1 receptor, which cannot take up that much load, but is very specific and can absorb the rest of it. So there is no glucose comes out in the urine, and that's how we traditionally used to check for glycosuria. This is an image of the SGLT2 receptor in the proximal tubule. You can see that the SGLT2 receptor is on the tubular lumen of the proximal tubule, and it absorbs the glucose into the cell, and then by GLUT2, it goes back into the blood vessels at the basolateral membrane. The SGLT1 receptor does the same thing, absorbs the rest of the glucose back into the blood vessels. The Tmax of a normal human being is about 180 milligrams per deciliter, which means if the glucose in the blood is over 180, you get glycosuria, which means there is glucose excreted out into the urine. However, in the diabetics, there is a change. The glucose transport protein expression is increased. The SGLT2 receptors are increased. The GLUT2 receptors are increased, which causes more glucose to be taken up, which means even if the glucose may cross 200, 220, 230, it does not come out in the urine. So there is more hyperglycemia. The mechanisms how we can change this is if we can give a medication that would lower this glucose threshold, and these are the SGLT2, the SGLT2 receptors blocking agents. So the first one that showed a cardiovascular improvement was empagliflozin, which is the EMPEROR trial. The SGLT2 empagliflozin, also called Jardiance, was given to 3,730 patients, and these patients were mostly having, these were all cardiovascularly positive, and the primary outcome was a reduction of, with empagliflozin versus placebo, of 19 versus 24% of improved cardiovascular death and of reduced hospitalization by heart failure. This was a great trial. It improved the use of this drug, Jardiance. However, recently, last year, fall, dapagliflozin, which is Farxiga, had a declared trial, which had 17,160 patients, which was a CVOT trial. The patients here, only 40% had established cardiovascular problems. 60% had multiple cardiovascular risk factors, but did not have cardiovascular disease as such. Farxiga given to these patients in a dose of 10 milligrams caused a 27% relative risk reduction in the overall population and 36% in the primary prevention subgroup. This was followed by another trial, the DAPA-HF trial, which had about 4,744 patients. And these were given to patients, 45% had type 2 diabetes, but surprisingly, 55% of these patients did not have type 2 diabetes, had only heart failure. They have heart failure with reduced ejection fraction, also called HFrEF. There was a 26% relative risk reduction in the overall population, and also a 25% in the type 2 subgroup. Looking at the next slide, you see patients who had type 2 diabetes given Farxiga 10 milligrams, which is dapagliflozin, and patients without type 2 diabetes given. You see there is a reduction of 25% in the patients with type 2 diabetes, but a similar amount of reduction in patients without type 2 diabetes. This makes us believe now that this is more of a heart failure drug rather than just a diabetic drug. And I think this should be used more in people with heart failure, in diabetics or non-diabetics. It does not matter. You just have to be careful in making sure that the patients do not have type 1 diabetes, which could lead to DKA. So, explanation of benefits, as we call it in our medical forum. I have to look at the EOBs. So what is the explanation of the benefit of the SGLT2? In the heart, it probably causes a reduced preload and afterload. In circulation, it causes systolic blood pressure to reduce and hematocrit to go up. In the kidneys, it causes the sodium glucose reabsorption to reduce and the sodium delivery to distal tubules to increase, and osmotic diuresis. And neurohormonally also, it improves the function. These are effects above and beyond what we use for normal heart failure drugs. So these patients who improved were already on ACE inhibitors, ARBs, diuretics, and multiple other medications that would improve the heart failure. So switching now to some of the other drugs that are not much used in diabetes, but which are pretty innovative in the way they are used. Bromocriptine, a quick release bromocriptine. This increases the CNS dopaminergic activity. The patients, diabetics especially, may have low morning levels of dopamine, and this may lead to hyperglycemia and dysfunction. Postprandial reductions happen when you give bromocriptine immediate release. This is mostly given in the morning. We start off with a 1 pill, go to 2, 3, usually 4 pills a day in the morning taken together work. The full dose is 6 pills in the morning. There is no hypoglycemia associated with this, and there are no major cardiovascular side effects or problems. The side effects mainly include nausea, dizziness, and fatigue. Switching now to some of the newer things, which are the continuous glucose monitors. We have all become quite used to this, I think, although we may not use them so often. These are now available more so because Medicare has allowed us to use these in type 1s and type 2s. This is the one you see here is quite advertised as the Abbott's CGM, which is called the Libre. You stick it on the arm, goes for 14 days. There's a little monitor. You get your glucoses every minute or two on it, and you can also put it on your smartphone. This is another one called the Dexcom. Very accurate, very nice. You can even have a smart watch that can monitor you. This is so unique and so nice, especially for the brittle diabetics. There's a third one. I do not have an image of that. It's called Eversense. Eversense is, which I have been doing since last summer, implanted under the skin with a small cut, and it stays there for 3 months, and it continuously reports all your glucose to your smartphone over 3 months without ever putting anything on. You can shower, everything, the skin is just looks normal. They are trying to get a 6-month one, which is already approved in the in Europe. If we can get that, we put a little implant in your nursing home patient or an elderly patient doesn't want to check his glucose. Even the family can monitor on multiple screens and multiple smartphones and take good care of their loved ones. Well, here comes the newer insulins. For the anti-hyperglycemic therapy, there is the ultra rapid acting inhaled insulin, which has been around. It's been around for a while, but it has not found much traction. Although this drug, which is Afrezza, I like it. I like it because, as you can see on this graph, it is ultra rapid acting. There are people who take your insulin injections, including the Lispro, Aspart, and Glulisine, and it's still their glucose dries up in the first hour or two, especially if you have a continuous glucose monitor on. The ultra rapid inhaled insulin is almost instant. It's almost like an intravenous shot. It goes in, and within an hour or two, it's gone, which means there's no tail end, there's no hypoglycemia because of lingering effects of the glucose. I have seen people who have continuous monitors on. As they eat, they take an inhalation of the insulin, their glucose comes down. If it starts to go up again, they eat more, they take another inhalation. There is no hypoglycemia. They're just in and out of the system. On the other end of this is the long-acting insulins. There's a long-acting insulins like Toujeo and Tresiba, which are not 24 hours, but are 36 hours insulin, which also improves the fact that they don't have peaks and troughs. When you give it, it stays like that. If you miss a dose, if you're late by 4 hours, 6 hours, you're not getting hyperglycemias. It continues to work, but you take it every 24 hours. Now, I must tell you about a newer patch. Of course, there are multiple different pumps, but this is called the Vigo patch. The Vigo patch is not a pump, but almost a pump. It's a mechanical device that you stick on, as you see here, and it injects insulin under your skin, right straight from the back of it. It has a little clicking device, as if you can see it, on the bottom part on the front. And if you click on it, it gives you 2 units of insulin. So each time you click, it gives you 2 units of insulin. And this is disposable. So it's a patch insulin delivery system. It's not called a pump, and it is approved quite easily. It is mechanical. There's no batteries, no chips. It delivers predetermined fixed basal rates. You have a Vigo of 20, 30, or 40, which will give you that much insulin slowly, like a pump, over 24 hours. On demand, you can bolus 2 units. You have a little snack, you can go 1 click, take 2 units. You have a large meal, take 4 clicks, which is 8 units. And it is easy to use, keep it simple, stupid. For the people who have difficulty understanding the complicated pumps, this is such an easy device. It is disposable, inexpensive, covered by most insurances, Medicare, Medicaid, commercials, uses less insulin, and is meant for basically type 2 diabetics and consistently lowers the A1C. In this graph, you can see the Vigo consistently lower the prescribed insulin dose. You see less insulin used with Vigo because it is given right on time, and people, get a better glycemic control. There is a powerful A1C reduction. People don't have to go look for their pens. They forgot their pen. I didn't bring it with me. It's on you. You go have a snack at 2 o'clock, 4 o'clock, anytime you want. You just take a click or 2, and it covers your mealtime insulins. So with that, I would like to conclude this saying there's a spectrum of options going from the old injectables with the NPHs down to the pens, and the pens went to inhaled insulins and the pump therapy. And of course, on the higher end, you have the closed loop systems, which the Medtronic devices and other devices have made closed loop systems, which will check your glucose and tell the pump how much insulin to give, or shut down insulin if you have low or hypoglycemic events. So there's a whole spectrum of things out there for glycemic control. There is more medications which help with cardiovascular risk factors. And with that, I will conclude. Thank you, everybody, for listening today. And thank you, Dr. Mehta, for being a co-host here. Dr. Mehta, any final words?
No, this is excellent. And thanks, Dr. Kumar. I'm an internist and all this was fascinating. It's always learn something new when you talk. So really appreciate your talk. We have like barely 3 minutes left. I had one question for Dr. Gopal, if you can take one, is do you use blood work like D-dimers, ferritin, CRPs, and anything else in the outpatient setting? And if so, what do you do with that?
We really honestly don't do too much in the outpatient setting because I don't think that these markers will be of much help. I think it's hard to, particularly in an outpatient setting, if the patient is not significantly ill, I'm not sure what the CRP ferritin will help us. D-dimer maybe, but I don't think there is any much use. I think we do this when the patient gets to the hospital. Obviously, we do monitor CRP, ferritin, and D-dimer also.
I appreciate that. And Dr. Jain, I've seen a couple patients where I think their CT severity score would be like 16 or something, and they're not even requiring oxygen. Somehow they got a CT scan. And you mentioned that it has got some prognostic value. Do you know if that data is good and what it is?
So as I mentioned in my talk, like this is a newer thing. Overall, in majority of patients, when you have like a CT severity score of 16, majority of those patients will be very sick. A lot also depends on the previous health condition of the patient, whether they are young or old, and the degree of opacification. Like if it is a very subtle ground glass density versus frank consolidation. So subtle early ground glass density is kind of less bothersome, but if it is a frank consolidation, that is more severe. That means there are like more exudates in the alveoli.
Great. No, appreciate that. So I guess it's more the amount of area that is involved rather than the type of involvement. And I guess that makes a difference in the presentation. Thank you so much. Dr. Kumar, any comments finally?
Oh, I should thank all of you, including all the people who spoke today and all the attendees. This has been the best turnout we have had in a long time. I think thanks to COVID, maybe it switched us over to this electronic medium, which has made it even better for us to disseminate this knowledge about COVID and all other medical things. So thank you, everyone.
Thank you.
Okay. Yeah, and same, I'd echo the sentiment. I think Aipno has always been there for us. It's our professional home locally. But this year, the amount of academic work, the productivity scholarly wise, and the amount that our physicians and other healthcare givers have contributed in the entire area to taking care of COVID patients, it has been huge. And all our thanks go out to everyone who has worked so hard to get us to this point. There's light at the end of the tunnel, and hopefully we will have vaccines soon for everyone. So all the best and enjoy the rest of the program.
Thank you.
Thank you.
Thank you.